We'll hear from Dr. Klausner, who will discuss biomedical strategies to prevent STIs and to prevent and treat STIs. Dr. Klausner is a professor of medicine at the David Geffen School of Medicine and a professor of public health at the Fielding School of Public Health at the University of California, Los Angeles. Dr. Klausner will have 20 minutes to provide remarks and up to 30 minutes for a Q&A. Dr. Klausner.
All right, well, thank you very much for inviting me to share some ideas with you today about biomedical interventions to control STIs. Having left public health, as an academic researcher, I do have a variety of different relationships with different commercial manufacturers, and also received grants from the NIH, National Science Foundation, and private for-profit and nonprofit entities. So what I was going to try to do in 20 minutes was just highlight some key theories which have to underlie our approach for recommendations and how we think about controlling STIs in the United States. And as many of you know, I was the STD controller after Gail Bolin in San Francisco from 1998 till 2010. So I do have some real-world experience in terms of running a very busy and at the time highly effective STD control program. And then I'll share with you what's new in research in terms of antibiotics and some new antibiotics that have been studied and are near completion for the treatment of gonorrhea. Then I'm going to talk to you about some older antibiotics and how they're being repurposed both for treatment and prevention. Then I'm going to highlight some advances in diagnostics with an emphasis on some of my work that's been funded by the NIH. And then update you on some initiatives related to vaccines for the prevention of STIs, remind us about the value and importance of condoms, and then also talk to you briefly about male circumcision. All these are biomedical interventions that can be used to control STIs. So the basis for our STD control efforts are based on the reproductive number, which I think you may have heard about, related to the transmission efficiency, which is the likelihood that when two people come in contact, when one person has an infection, the likelihood that infection will be transmitted. The contact rate, or the number of partners in any given time, can be at an individual or at the community level. And then the duration of infectiousness, which is something that we focus a lot on, identifying people with infection early, treating them to render them non-infectious. And there's no better example of the success of that than Mike Cohn's work and the efforts that have now developed into U equals U, where undetectable for HIV equals untransmissible. And the goal is to reduce the reproductive number to less than 1. So that really means that one person contributes fewer than one additional infection in the population. And an epidemic will increase if that reproductive number is greater than 1, and that's currently what we're seeing with syphilis and gonorrhea and chlamydia in the United States. Second key theory is called core group theory, and this is critical because actually the gonorrhea prevalence overall in the United States is less than 1%. And it's estimated that in the general population, the reproductive number is actually less than 1. So 40 years ago, scientists recognized that there must be a core subpopulation that has to exist to sustain endemicity in the population. And without that core group, STDs would disappear. And that core group has been very defined as people with a certain number of sex partners at a given time, people who may engage in transactional sex for work or housing, or certain other minority or other subpopulations. And efforts that focus on disease control in those core groups can actually have a substantial benefit for the overall population. So I'm going to focus on one of our biggest threats is the threat of drug-resistant Neisseria gonorrhea. A couple weeks ago, CDC estimated that over 500,000 of our gonorrhea cases in the United States are drug-resistant, and this has an annual cost of over $100 million to our society. So this is not new. 40 years ago, headlines in the New York Times and the Post said that there's a new strain of VD out there. It could be incurable. There's a new gonorrhea fear. So why are we still facing this 40 years later? And that's because every time we introduce a new antibiotic to treat gonorrhea, that antibiotic has a half-life. It only works for a limited amount of time. The gonococcus is a particularly wily organism. It has a unique ability to develop mechanisms of resistance in that bacterial cell that will then eventually render that antibiotic no longer effective. And our traditional strategy has been just to pull a new antibiotic off the shelf and then treat gonorrhea, all the cases in the United States, with the same drug. And what I've been thinking about and others is a new strategy in terms of treating gonorrhea. So the traditional strategy is development of new drugs. So these are the 3 new drugs that have been studied in the past couple of years. So lithromycin was a new drug in development. It seems that the development of that drug has currently been paused or halted due to some issues related to efficacy. Gepotidacin, which is a new drug with a unique mechanism of action, somewhat similar in class to fluoroquinolones, and that drug is now entered in phase 3 clinical trials across the United States. And a third drug, zoliflodacin, is also in phase 3 clinical trials. And the interesting about this drug, it's developed through a private-public partnership with the manufacturer, WHO, and the NIH. So all drugs are also being studied. Ertapenem, which is an injectable antibiotic, which can be given intramuscular or IV, 1,000 milligrams. And current studies are looking at it 1,000 milligrams, either intravenous or intramuscular a day for 3 days. And you've heard about the drug-resistant, ceftriaxone-resistant cases of Neisseria gonorrhea in Europe and in Asia, and some of those have been treated with this drug, ertapenem. Fosfomycin has also been studied in Europe. That's an oral drug often used for urinary tract infections, promising efficacy with fosfomycin. Ciprofloxacin, going back to older drugs, so recycling drugs for Neisseria gonorrhea treatment, which I'm going to talk a little bit further. Doxycycline, an older drug also for rectal chlamydia treatment, is in clinical trials. And doxycycline for STD prevention, which I was particularly requested to speak about, is now in randomized clinical trials in Seattle, San Francisco, Vancouver, Sydney, Melbourne, Paris, and even Kenya. And I was going to spend a couple minutes talking about ciprofloxacin for Neisseria gonorrhea treatment and doxycycline for STI prevention. So based on the CDC gonococcal isolate surveillance report, or GISP, from 2018, as you can see, about half of all gonococcal infections are actually susceptible to any antibiotic. We could use amoxicillin, penicillin, tetracycline, azithromycin, but the challenge in clinical practice, we don't know if that infection is susceptible or not, so we treat every infection the same with a sledgehammer called ceftriaxone. However, 69 or 70% of all these infections are actually susceptible to ciprofloxacin, a very safe, inexpensive drug that's highly efficacious at all anatomic sites. So it was discovered in 1996 by Japanese scientists that there was a single point mutation in Neisseria gonorrhea that conferred resistance to the ciprofloxacin. And a few years ago, a medical student and I at UCLA, we reviewed over 5,000 isolates over 20 years in 16 countries, and we found that this single point mutation was both necessary and sufficient to detect resistance in 98.6% of infections. So we're all familiar with molecular markers in HIV and how we use genotypes to predict HIV resistance, hepatitis C, tuberculosis, but no one before had really introduced this into clinical practice. So in 2015, funded by the NIH, we introduced a new assay called the reflex GyrA assay into clinical practice at the large UCLA health system, 2 hospitals, 65 primary care clinics in the Los Angeles area. We found that by using this assay, we could actually reduce the use of ceftriaxone and azithromycin combination therapy from 94% to 76%, thus potentially preserving the use of ceftriaxone for future use. And as you can see in this slide, by quarter, the lack of ceftriaxone was replaced by the introduction of ciprofloxacin. So when providers have these test results, they could actually select ciprofloxacin for the treatment of the gonococcal infection. NIH, through the STAR, Sexually Transmitted Infection Clinical Trial Group, or the STI-CTG. Many of us have heard of the ACTG, which is the AIDS Clinical Trials Group, but there's also an STI CTG that I was the lead of one, and Dr. Hook was the lead of the other network. But in our network, we did a prospective clinical outcome study of ciprofloxacin, 500 milligrams, single-dose therapy in these wild-type Neisseria gonorrhea infections. We did this in 8 different clinics. At the end of the study, we had 117 culture-positive wild-type infections, and we did a test to cure at about 5 to 7 days. And as you can see in this slide, in what we call the per-protocol population, we had 100% efficacy of ciprofloxacin for the treatment of gonococcal infections based on this assay at any anatomic site. And this figure just shows the same information, but in graphic form. So very confident that this assay is a very strong predictor of clinical outcome in patients treated with Cipro. The use of this assay in what's called resistance-guided therapy has been adopted by the British Association of Sexual Health and HIV Medicine, called BASH, and we're expecting CDC guidelines in 2020 will also include a nod to the use of resistance-guided therapy. The advantage of resistance-guided therapy with ciprofloxacin, it's inexpensive, it's an oral therapy, easy to use for partner treatment. We've heard a lot today and over the past few sessions about expedited partner therapy. It's safe, highly efficacious, and it might reduce selection pressure and save the use of ceftriaxone. And importantly, the goal of research is to then stimulate new companies and commercial development. So several companies are bringing Neisseria gonorrhea resistance assays to the forefront into clinical practice. Expedited therapy, I just wanted to remind folks that this is a biomedical intervention strategy. We're using medications in a public health approach to treat partners who may not all be infected, but because are at high risk for infection, are worthy to be treated. And many states recommend partner therapy regardless of the sexual orientation of the index patient. Some states have limitations in terms of the sexual orientation or the sexual practices of the individual. But this is an evidence-based biomedical approach to STI control. Now I want to switch gears to doxycycline prophylaxis. Doxycycline historically has been studied as prophylaxis for a variety of different infectious diseases, including traveler's diarrhea, typhus, leptospirosis in the U.S. military, and Lyme disease. So those from the East Coast, if you're out hiking, you get bitten by a tick, a single dose of doxycycline, 200 milligrams, has been shown to be highly efficacious to prevent the development of Lyme disease. So Bob Bolin and I at the Los Angeles LGBT Center did a small pilot study where we randomized 30 men to either daily 100 milligrams of doxycycline versus a behavioral intervention where we gave people a $75 gift card if they came back and were STD free. We enrolled 30 men and had a 48-week follow-up. We saw a 73% reduction in any STD, and this was particularly driven by a reduction in cases of syphilis. And we did not see any impact on gonorrhea, which we would not have expected because much of gonorrhea is already resistant to tetracyclines. Now, one of the best things that can happen when you do a pilot study is someone smarter and with more resources replicates it in a stronger study. And this was done by Jean-Michel Molina, the founder of the 2-1-1 PrEP approach, who looked at post-exposure prophylaxis with doxycycline to prevent STIs in men of sex of men. And instead of 100 milligrams a day, he recommended, or his study was 200 milligrams once after sex up to 72 hours. So PEP, or post-exposure prophylaxis. In his study, PEP with doxycycline reduced all STIs by 47%, and specifically syphilis by 73%. So the exact same risk reduction that we saw with our small study in Los Angeles. Other investigators have looked at the acceptability of doxycycline prophylaxis for STI prevention, mostly among men of sex and men, in this app-based study across the United States. And 84% of these over 3,000 survey respondents said that they would likely use doxycycline for STI prevention. Modelers in Australia have looked at what proportion of uptake and proportion of the population do you need to reach with doxycycline to actually eliminate syphilis. And in this modeling study, they found if they reached half the men who had at least 10 partners over 6 months, they could reduce that reproductive number of syphilis such that syphilis in a 10-year period would disappear. Last year at the CROI meeting, AIDS research meeting, we convened a group of experts from around the world to talk about doxycycline prophylaxis for bacterial sexually transmitted infections. The major concerns that were raised was resistance, particularly of other pathogens like Staph aureus, gram-negative enteric infections in the GI tract. However, there's never been a documented case or laboratory-based finding of doxycycline resistance in syphilis or chlamydia trachomatis. There was a discussion about the long-term safety of antibiotics, particularly on the microbiome, and Drs. Golden and Hansfield, who some of you know well, raised some issues about risk versus benefit. Preventing a treatable disease like syphilis versus preventing complications like neurosyphilis or ocular syphilis, and what would the number needed to treat be, or the cost effectiveness. Now I'm going to switch gears in my last 4 minutes to diagnostics. So we went from antibiotics used for partners, antibiotics used for prophylaxis, to diagnostics. So this shows this Expert Infinity machine, which is a extremely large 80-unit machine that can run a STD test in under 90 minutes. And now these express clinics, if you will, in the United States exist in Fort Lauderdale, New York City, Los Angeles, and coming in Boston and Mississippi. And these machines allow for same-day testing and same-day treatment. So in Los Angeles and New Orleans, through an NIH-funded study called the Adolescent Trials Network, we were able to show that the use of same-day testing and same-day treatment had a substantial increase in the proportion of individuals treated the same day and the proportion of adolescents who were treated within 30 days. So it's critical we don't just build systems of care, but we build systems where we can get people treated and treated in a timely manner. So there have been advances in rapid STD diagnostics. In August 2019, a few months ago, Binks was cleared as a 510K device for rapid detection of chlamydia and gonorrhea. This is aimed to be an office-based diagnostic that can be used in clinicians' offices around the United States. A second is coming to you by Biomedical, currently in clinical trials, and we expect perhaps as early as Q3 next year that this device will be FDA approved and CLIA waived. This means that fairly minimally trained individuals will be able to run the assay, and also leads us to an assay that potentially could be over the counter at some point in the future. The Biomedical device is a rapid detection system for chlamydia, gonorrhea, and trichomonas. All the device manufacturers are also thinking about adding in resistance markers like that GyrA assay I told you about, and potentially other markers for other pathogens as well. Point-of-care rapid treponemal test. There are FDA-cleared tests. There's one currently called the Syphilis Health Check. WHO a couple weeks ago came out recommending that every pregnant woman should be tested with a dual syphilis test. So we don't have any dual HIV and syphilis tests available in the United States. But a dual test means with a single drop of blood on the single device, a woman can be tested both for HIV and syphilis in that same blood test. So these tests are widely available outside the United States for as little as $1.10, but none are available in the United States for dual testing. The rapid single syphilis test is indeed available and is being used by many health departments in the country. So a basic question as we think about testing is, can testing decrease STIs at the population level? There's actually some evidence from work in San Francisco that increased testing did bend the arc of the epidemic in the early 2000s. There's increased evidence from Australia that more frequent testing leads to a decrease in early syphilis cases. Last week in Paris, they reported there was a 14% decline in syphilis from 2017 to 2018, and the thought is that due to the increased testing, particularly for syphilis in patients receiving PrEP. The evidence that chlamydia screening reduces sequelae is actually fairly strong. Chlamydia screening reduces the duration of infection, leads to reductions in pelvic inflammatory disease, ectopic pregnancy, chronic pelvic pain, but there's no evidence that it reduces prevalence. This was a large study by Jane Hawking in Australia, a 63-clinic randomized controlled trial, and there was no change in positivity, but there were change in those health outcomes. So my point is we have to kind of rethink a little bit by disease what our strategies are. Testing probably does work for syphilis. Testing works for chlamydia to prevent adverse outcomes, but not necessarily positivity. And then for Neisseria gonorrhea screening, there's no evidence that increased testing yet has reduced the burden of disease in the population. And there are concerns that increased testing and detection, particularly among asymptomatic individuals, may actually be driving resistance. Labeling people with an STD that may clear on its own in a period of 3 to 6 months, and obviously increased cost to detecting asymptomatic infection. So we take for granted that screening for gonorrhea is a good thing, but we do need sometimes to challenge our assumptions. So lastly, I'm just going to talk about vaccines. So the meningococcal type B vaccine. So most of you have teenagers or people or know people at risk have been vaccinated for meningococcal type 4. But there's a second type of meningitis called meningococcal type B. And that is recommended, but it's not universally given in all populations. But in New Zealand and Alberta, Norway, and Cuba, for different periods of time, there were large population-based programs for meningococcal type B vaccination. And the researchers have gone back, the epidemiologists, and looked at the impact of this meningococcal type B vaccine on gonorrhea, and actually saw a drop in gonorrhea cases about a year to up to 5 years after introduction of those vaccination programs. Because of that exciting epidemiology, the manufacturer is now partnering with NIH to initiate a study starting in July 2020. And Australia just announced last week that it will be funding a study as well, a population-based study in menosexed men for meningococcal B vaccine to prevent gonorrhea. Peter Rice, University of Massachusetts, has an Neisseria gonorrhea peptide mimic vaccine, which is going to be entering clinical trials soon. And there's modest hope on a chlamydia trachomas vaccine. There was a phase 1 study recently reported, and a syphilis vaccine remains far away, but Carolyn Cameron in Vancouver has shown some immunogenicity with a specific T. pallidum peptide. Condoms is another biomedical intervention. We don't want to forget the importance of condoms, condom promotion, standardizing condom access in all our sites, and we should never lose focus of the substantial protective effect of condoms. And lastly, I want to wrap up with male circumcision, and this was a fairly recent study done by the University of Washington, folks in Kenya and Uganda, that showed that male circumcision was associated with a 42% reduction in syphilis incidence. So our male circumcision rates in the United States are about 48%. We could do a lot more to promote male circumcision as a newborn intervention, which would have life-saving effects later on. So in summary, I talked to you about antibiotics, the new antibiotics, smarter use of old antibiotics, diagnostics, vaccines, promising, long way off, needs investment, condoms, and male circumcision. So thank you for, oh yeah, one last thing. So as I've been thinking about this and I talked to the media, we have a lot of focus on personal responsibility and that generates morality and issues of individual behavior. But I think we really need to move to public health accountability, as public health programs, when funded, can control the spread of these sexually transmitted diseases. Thank you very much.
Thank you, Jeff. Patty, and then John.
So this is more of a question that, I'm sorry if I'm naive on this, but I thought like the STAR, isn't that defunded now, or didn't they move to something else?
Right, so the question is about the NIH Sexually Transmitted Infection Clinical Trials Group. So basically there's 1 to 2 years left on the contract. They're not initiating any new activities. They're allowing those to sunset, and those are moving to this quite complex and potentially burdensome, no opinion, model called the Infectious Disease Clinical Research Consortium, IDCRC, which is going to be a program to fund 5 areas of infectious disease research, from malaria to STIs to respiratory infections to emerging infections as well. So we've lost our specificity from the NIH, which I think is problematic, but that's what we have.
Thanks for that. For some of the point-of-care tests, are those are specimens site-specific, or does it matter?
No, so the point-of-care tests are specimen agnostic, so they don't particularly know where the specimen came from, and they've been validated in pharyngeal, rectal, vaginal, urethral, urine. There's a lot of movement towards self-collection we've heard about, and for validating self-collected specimens.
And then any data that you're aware of on male circumcision as protective for MSM specifically?
For MSM in terms of HIV, there is some data when you can stratify individuals who are predominantly tops and insertive are protective, but because we know that most MSM are actually versatile, that effect seems to be diluted if people are practicing receptive anal sex.
Thank you for a great talk. So I was reflecting when you were talking about like the world as it exists and you're going through different drug products, and I was thinking like I think you had 2 products for gonorrhea. We have 30 effective agents for HIV, but yet the list of long-acting products under development is like much, much longer. And I'm just wondering, like, should we be thinking much bigger about our biomedical investments, or is this not where? And if it was, like, what, like, I almost like would like to imagine, like, what's our moonshot? What's our compelling vision for like what biomedical investments could yield us? Do you have thought, like, should this be a priority, and what would it be?
Yeah, I mean, I think, the challenge you're depending on a free market and a capitalist system where the developers are looking for, adequate return on their investment. So to conceptualize return on investment of a single inexpensive oral dose of an antibiotic, just no one can wrap their head around.
Can NIH do more though?
Well, I mean, NIH has been supporting, some of these studies, and, NIH, the past 10 years has, been an engine of discovery, transferring the intellectual property or access to intellectual property to companies. I mean, that seems to work, and companies, come in and partner with that. But, I think the, moonshot really is about vaccines. And I think, that would enable us not to have to educate anyone, and wouldn't have to, talk about behavior, wouldn't have to stigmatize. We've had our most success in the control of any infectious disease with vaccines, right? There's been 2 viruses eradicated from planet Earth, smallpox and rinderpest, and both of those have been through vaccination programs.
Right. And then a quick question. You mentioned gonorrhea, asymptomatic gonorrhea clearing on its own. How often does that happen?
Well, some studies from University of Washington that Lindley Barbie presented, I think at one of the recent meetings, says about average duration of infection is about 4 months. There's a range there. So people do clear infection. There's going to be some people who will persist longer, some people who will clear faster.
Jeff, thanks for a great presentation. So I was actually struck by your last slide, from private responsibility, public health accountability. Could you expand a little bit more on that? And, does that sort of deal with the implementation of these tools and in different settings?
Yeah, well, I mean, sometimes, it's not necessarily a popular opinion, but I think sometimes about public health, disease control, like we're veterinarians. And, we have an outbreak in our herd of cattle, right? We're not going to encourage the cattle to reduce their behavior. We're not going to encourage the cattle, not to have sex with their, cattle next to them. We're going to do some population-based structural intervention. We're going to separate the cattle. We're going to vaccinate the cattle. I mean, unfortunately, there's a lot of widespread antibiotic use in the cattle has led to lots of different problems. But, I think we have to think more on a population level. Dan mentioned the importance of structural interventions, and what structural interventions can be put in place. Is also a nascent movement around sexual health does not necessarily mean disease-free. So we've heard a little bit about, STDs are a normal part of human sexuality. So you bicycle, you skin your knee, you ski, you might, break your knee. So it's a normal consequence. And, we need to think about what are we trying to do by controlling which STDs, what's the value of the specific STD control.
Jeff, you presented an enormous amount of data, and I thank you for it. It's very thought-provoking. I'm going to have to really think about your cattle metaphor there for a while. With resistance-guided therapy, there were two questions I have for you. The first is, are there antibiotics other than fluoroquinolones where that might be active? As you pointed out, fluoroquinolones is just this one mutation. And my second question for you is that just before you talked about resistance-guided therapy, you talked about this inexorable development of antimicrobial resistance. Have you modeled what the threshold is and how much time or what the cost benefit is for how long of resistance-guided therapy? Is it just I presume it's temporizing. How temporizing?
Right. So the first question is, are there other antibiotics that have relatively simple mechanisms of resistance? So we did a review now of about 2,400 sequences of Neisseria gonorrhoeae for ceftriaxone resistance, and we can actually get that down to about 6 codons. So potentially we could develop, and we have some grants under review to develop a short sequence-based assay to predict ceftriaxone resistance, and I have to disclose a patent pending on that. And then zoliflodacin. So one thing with the introduction of these new drugs, which I've been trying to get people to think about, is we should be introducing those new drugs with resistance assays, at the same time. So zoliflodacin, being a relative fluoroquinolone class, could be amenable to, a very, very simple molecular marker to predict resistance, and you would avoid the use of zoliflodacin if you had a potential resistant isolate. And then in terms of modeling, so the woman Tuitte, do you guys know her? She's a modeler.
Pronounced chute.
Chute. So she's modeled on this, and she's looked at assays that predict one resistance to antibiotic, multiple resistance to antibiotic, and has shown a delay, but not an abrogation of resistance. So, and in her model, the delays were about 10 years. But it all kind of depends on what the different driving factors are, how resistance relates to fitness. I mean, one interesting thing is that Cipro resistance still persists, even though we don't routinely use Cipro anymore to treat.
So we have a couple of questions from our folks online. Mike, Sten, and then we're going to go to Carmen and Patty. Mike?
Mike Cohen, can you hear okay?
Yes, we can.
Oh, great. Jeff, there's like this, I have a question about, you introduced Gene Expert and also introduced point of care testing pretty aggressively. The question is, where will those things be done? Because there's a tension, and it was expressed already about like how overwhelmed the STI clinics are. The volume in any private doctor's office is too small to justify maybe the investment. Gene Expert, of course, is an investment that would be a big commercial investment. And then there's the notion of pharmacies doing more and more, and minute clinics doing more and more, but they're not necessarily. So I'm just curious where you come down on the deployment of these tests.
Yeah, so I mean, we've actually modeled this outside the United States in Botswana and came up with like a spoke and wheel kind of model for deployment, that not every primary care clinic has to have it, but just some have it, and then some of the more remote ones would send their specimens there. But in the United States, I mean, Walgreens made a huge strategic mistake by partnering with Theranos instead of Cepheid. And the plan was to put these devices in, Walgreens minute clinics or whatever they're called, to be able to do flu diagnostics and diarrheal diagnostics and have, rapid point-of-care test systems available, and that people could manage the results either under protocol, if they're nurses, or not. So I think in those kind of settings, that would be appropriate. And then also we've seen them being deployed into large community-based organizations, the LGBT centers in these major cities. And then my dream is they'll be right next to every ATM machine. So with the myriad of ATM machines you have around, you could have these machines as well, where people could self-collect, introduce specimens, and have the results texted back to them.
Sten?
Jeff, Sten Vermont here. Would you comment on sort of the segmented audience for PrEP versus doxycycline for STDs? Do you think that there is a much wider community demand for doxy, a smaller community demand? Will it pretty much overlap with people who are interested in taking PrEP?
Well, I think it will primarily overlap with people interested in taking PrEP, and my thoughts are we should be using it in those core groups, and that's the intervention that you want to use for the core groups. So in STD clinics, in sexual health programs, and HIV care clinics, it's not going to be everyone, and there are some places that are recommending it and using it, for example, in men who have 10 or more partners a month. So, that's an individual with high frequency exposure and potential high frequency transmission, and to, render that person non-susceptible to syphilis or chlamydia could have an impact. The benefit of chlamydia in that population is, of chlamydia prevention in that population is less certain, but also, sex workers would be another, potential appropriation. But I think it would have to be targeted, and the idea, at least my idea, was never to, roll it out for broader population use. But knowing that 200 milligrams as a single dose after a sexual contact is effective, may be an option for some people when they're, having a contact that they think might put themselves at risk.
Yeah, thanks so much for that very wide information. I'm curious about. I'm very excited about point of care testing for syphilis. I didn't know that there was some approved for the U.S. And I'm wondering whether we could actually consider point of care testing for syphilis in labor rooms, as we did for rapid HIV testing for women who didn't have prenatal care or didn't have HIV testing during prenatal care. So, because that's a group that's particularly at higher risk for transmitting or for having neonatal syphilis. The other point that you made that was interesting was neonatal circumcisions, because at one point I actually discussed this with some of the patients from our clinics, and I thought, well, women living with HIV who have male infants might be more open to having their children, their infants, having neonatal circumcisions, thinking that it's socially acceptable and might have some impact in the future. So that was interesting that you mentioned it. Do you want to comment on those two things?
Sure. Those two things about point of care syphilis testing. So the Association of Public Health Laboratories convened a meeting I was at in Atlanta, must have been about 2 years ago now, a year and a half ago now, where there were presentations on point of care syphilis testing, and those recommendations are soon to be published through support of the CDC. And I think, it's going to take a little bit of thought about what the best population to use those rapid treponemal tests. So they're treponemal tests, so they don't differentiate between old infection or new infection. But certainly, a labor and delivery setting where a woman has not been syphilis tested would be appropriate, and then it might take some interpretation from the provider in terms of whether treatment is indicated or not. Unfortunately, it's a little bit late at labor and delivery to be treating a pregnant woman to prevent congenital syphilis. It has to be done, earlier on in the pregnancy. So ideally, you want to do it, consistent with the new WHO recommendations, is that the first antenatal care visit, a woman should have a, test both for HIV and syphilis, which are recommended, but the implementation of that is certainly not 100%. So I'm a little bit more hopeful about dual tests than single tests. And in terms of, newborn circumcision, I haven't really been afraid to address that, but it is a controversial area. So there's controversy about from children's rights advocates, is this some kind of unnecessary intervention that a male should have an opportunity to request when they're older. We counter that we vaccinate children with vaccine. We vaccinate infants for their benefit. It should be left up to the parents or the guardians to make those choices. But I think newborn circumcision is a cost-effective means to increase circumcision rates. And as I said, we're at 48%. And unfortunately, we just did an analysis showing that the newborn circumcision rates have dropped most precipitously in states where states control what Medicaid services that they cover, where states have defunded newborn circumcision. And those states tend to be, and those populations tend to be the ones that would benefit the most from it. So we've also tried to get the U.S. Preventive Service Task Force to take up newborn circumcision as a recommendation. They say, well, we don't do surgical, prevention interventions. We only look at pills, I guess. I don't know. But I think this group could recommend to the U.S. Preventive Service Task Force to take up newborn circumcision.
So Jeff, thank you so much. You've presented so much innovation in research. It seems like we're doing great, but I don't think we are doing great. So could you give some recommendations? Where do you think, what recommendations should we give in the biomedical field? What are the top 3 or something like that?
Yeah, so I mean, it may sound great, but there's really only 1 or 2 people, 3 groups working on syphilis vaccine. We really need to increase the investment there. Give a plug for UCLA, James Miller. I mean, he did come up with a sterilizing syphilis vaccine in the 1970s. Required 60 injections, and it was only efficacious in rabbits. But nevertheless, it was a proof of principle that it could be achieved. And then because syphilis cases came down, funding went away as well. So I think, investments in vaccinology, remain key. I think more implementation science work needs to be done. So we have tools. We kind of think we know how to best use some of those tools, but we need to implement them. Things, that they've done in Washington State or in King County, or we had done in San Francisco, or, other sites need to implement and study. So NIH often sees itself not as, about implementation. And I personally come up with ideas to NIH and they say, well, that's CDC. And then we know CDC does not have the resources to fund studies like that. They can do program evaluation, but that's usually, a lot more limited than a, implementation science project. So we really need much more implementation science, vaccinology, and then, I think we should be happy about the investment in the Doxycycline prophylaxis across those various clinical trials. But we do need more resources.
Thanks. This is kind of related to the doxycycline. We also have another kind of post-exposure prophylaxis for pregnancy around the Plan B. And what we found actually is that few women, even when they're given it for free prophylactically, at a family planning provider, actually take it. And so I just kind of wondered in terms of, this goes to kind of perceptions of risk and then also general affordability. I mean, if you
don't have it. If you go to a pharmacy, it's like $50 for something that's costs really pennies to make. And I just kind of wondered about your thoughts about that in terms of how much it might cost, and also, what it would be kind of, human behavior in terms of taking this.
Right. So, I mean, doxycycline now is generic, so it's relatively inexpensive, but I'm sure if it was packaged and marketed in such a way, and, someone created some IP around that, intellectual property around that, product for that, purpose, the, price could go up. And that may, put it at reach, but it's also, something that, could be easily available in the public sector, and it could be introduced in whatever form of sexual health education people get in the school system to be made aware of it. We did a lot of different things using the internet and making medications available on the internet and prescriptions available on the internet as a health department. In San Francisco, we actually made Plan B available through the internet in San Francisco. So health departments, the state health departments, and that's why I mentioned public health accountability, that we need to, demand more from our public health departments, whether it be state or local. I mean, they cry they have no funds, no resources, but they could do more policy-wise. They could do more implementation-wise. Gail was fantastic and continues to be at sending out communications and letters and updates and interpretations of existing rules that enable providers or health departments to act. So we need that kind of leadership that we really don't routinely see.
Very much for your comments and for your time and your thoughtful information.